Thanks, Vasiti. Should we do a dance or hear another presentation? You want to just, anybody get up and stretch and take a deep breath? There is still some oxygen in the room, I think. Yeah. Okay, so Amy and Vasiti's acts are a little bit tough to follow here. And I'm going to get into some more, sort of activities. I'm going to try to keep it a little bit light, and I'm going to try to draw out some kind of big themes. And in that spirit, I'd like to start by just acknowledging CDC as being, really having done a magnificent job over many, many years in the Pacific Islands. I think that CDC for PIHOA as an organization is one of our really main closest partners, but in the individual jurisdictions in the Pacific too. There's just been years and years consistently of a deep river of talent of CDC folks involved in all kinds of different ways in public health in the Pacific Islands. And I'll touch on some of the really quite magnificent accomplishments that CDC has had working in the islands over the years, just in the context of my notes here. I think I'd like to start with getting back a little bit more about context in the Pacific Islands, and Amy did a really nice job of looking at the social and environmental context of public health work in the Pacific. I'm going to say a little bit about the institutional context of work in the US API. And then I'm going to get into a couple areas of work related to performance management and health information systems, just to kind of give some, a couple of kind of object examples of the type of work that we do. And then I'm going to say a few words about how I think that PIHOA as an organization complements what CDC does in the region. So first, for context. I think CDC does most of its work in the U.S. States where there's a very particular, and one might say peculiar, health and public health system that's very kind of, deep schism between public health and curative medicine. And in the islands, it's not really like that. And that brings up actually some very exciting opportunities for doing public health work. And, but there is still a spectrum that varies from place to place. And here's what it looks like for private medical sector, okay? And there's 3 jurisdictions that have strong private medical sectors. Really, Guam is the only one that's to the extent of the U.S. mainstream, that most of the healthcare is delivered in the private sector. And then a lot of our jurisdictions in pink there are really single payer systems and really single deliverer healthcare systems, essentially. The second thing that sort of goes along with that is Medicare and Medicaid. And so the flag territories, which are in blue, have Medicare and Medicaid. And that means that you can do a lot of stuff. The other day we were talking about Vaccine for Children's program, that can, sustain paying for vaccines. But only in those 3 jurisdictions. In the freely associated states, the pink ones there, there's not that opportunity, and that brings up problems. The third one is unified public health and curative services, and those in blue are essentially, single payer, single deliverer systems, and the ones in yellow are somewhat, and there's really nobody in the US API that's kind of like the US where it's really, really separate. So that really, it's kind of amusing looking at it from the island's perspective. of all the contortions and gyrations that we go through in the U.S. states to try to integrate public health with curative services. And in the islands, actually, it's much, much easier to do that. But you kind of have to be tuned into that and be thinking about that, especially when you're doing public health programming work from a CDC perspective. Oh, what kind of opportunities are there out here that there's no way you could do them if you were operating in Kansas or Oklahoma? And then the other one is traditional leadership. And in a lot of our islands, those structures are as strong as government leadership institutions are in those islands. And that's something that we really don't, it's kind of off the radar in the US. But there's a lot of very interesting stuff that can be done with policies that have to do with village-level policies and traditional clan leadership and the rules that are made regarding especially behavioral risks and access to collaboration with communities working through traditional leadership. And then another one is that some of our jurisdictions, and becoming more and more with time, have dominant community health centers. And what I mean by that is that HRSA-funded Bureau of Primary Health Care, CHCs, deliver much or most of the primary care in the jurisdictions. And the ones in blue, almost all of the primary care is delivered by community health centers. In yellow, it's somewhat, and in pink, not really. But having community health centers that really put a strong emphasis and require monitoring of metrics related to preventive health services delivery can be a really great opportunity for public health programs. And unfortunately, in a lot of our sites, the public health programs are still sort of operating from a funding point of view and a technical assistance point of view. It's like focus on the funded people and don't really think beyond that. And wait a minute, there's this delivery system that's kind of, I don't know if monolithic is the right word, but is out there. And a lot of the hands-on actual delivery of services, clinical preventive services, can and should be done in the broader primary health care setting. And the public health programs don't have to run their own clinics for certain things. They can just do the public health, population level management, the surveillance, and that sort of thing. Okay, so anyway, that's a bit of the institutional context. And then this next slide is just to show that in terms of health status and patterns of illness and risk factors, there's a large difference both between the US and the islands, but also among the various islands. And TB is just an example of that, where a few of the islands are sky high in their incidence of TB. And some of them are down close to what the US is, but the higher ones are many orders of magnitude above what's in the US. And, there's a lot of, I'm not going to get deeply into it. I just sort of off the top of my head sort of listed some of the things that are kind of interesting about the epidemiological profile of the islands. And there they are. And just to pull out a few, obesity, one of our jurisdictions, American Samoa, has, for overweight and obesity in adults, has the highest prevalence ever recorded anywhere worldwide. 93% of the adult population is overweight or obese, according to the last community-based survey. And then, the patterns of diseases, cancers are different in the US API compared to the US. Cervical cancer, lots more. Breast cancer, not as much. And then there's the epidemiological transition with a big problem with NCDs, actually much worse than the US, but also continue like tuberculosis and a lot of the infectious diseases, nutritional-based diseases, undernutrition among young children in some jurisdictions, micronutrient deficiency, sort of coexisting with the NCDs. So there's other tropical diseases still prevalent. Leprosy, RMI, and Federated States of Micronesia are two of the only countries, of the few countries left worldwide that haven't brought leprosy, under control. Lymphatic filariasis is on its way out. It was prevalent all over the region. Right now, there's still little pockets in the Federated States, but it's just about gone. Suicide, schizophrenia, very high, but opioid problems, blessedly low in the Pacific. HIV very low, but the other STIs quite high compared to the US. And as Amy mentioned, one of the most natural disaster prone and emerging infectious disease outbreak prone regions in the world. So there's a lot of kind of interesting stuff about the EPI in the US API. And then there's a lot of also interesting stuff about what can be done and what has been done. And the US API can be perfect innovation incubators. They're manageable size populations. They're geographically circumscribed. It's really easy to tell where the population starts and where it ends. The information systems are actually a lot easier to tap into what's going on within the entire population than it is with metropolitan populations. And there have been some great successes. The recombinant Hep B vaccine, the proof of effectiveness was done by CDC in partnership with the CNMI Division of Public Health back in the 1980s. Short course, multi-drug resistant TB prophylaxis, a proof of effectiveness of a 3-month course including fluoroquinolone treatment was done in Chuk. NCD core surveillance and policy framework, which was really something that hadn't been done anywhere worldwide. It was first done regionally in the US API. Right now, starting last year and coming into this year, there's mass screening for leprosy and TB of entire adult population in the RMI major population centers of Ibai and Majuro. And on the TB side, that's never been done using the relatively new technologies of gene expert, cartridge-based testing and digital X-ray for immediate identification of cases, real-time identification without having to send specimens or incubate specimens or, develop X-ray slides. So, and then a lot of interesting dental preventive treatments, xylitol and fluoride dental varnish, use of community health workers who are trained specifically for those skills and deployment of those technologies, silver diamine fluoride application for caries, for arresting caries without drilling and without fillings. All of that's been done in the US API. So, okay, now, when I was asked to prepare this presentation, it was about performance management, and PIHOA was lucky enough, together with our member jurisdictions, to receive NIFI funding back a few years ago when it started, and up until the time that the program was curtailed in 2014, I think it was. And at that time, a lot of our health systems development work, we were doing it kind of using the framework of the 10 essential public health services and the FAB standards for accreditation. And what I did with the presentation, which I'm not going to show all of you guys, is I went through domain by domain and showed that even since our funding dried up for NIFI, that most of our health, if you look through the domains, the FAB domains, we've actually still got ongoing work that fits in to each one of those domains. And I bring that up because a lot of the work that you guys do is problem specific, and even though in recent years you've really tried to kind of lump those problems together, TB, hepatitis, HIV, STIs together, the NCDs together instead of separate. But still, I think by its nature, CDC is kind of focusing on particular problems, whereas PIHOA is focusing on health systems strengthening. But we do a lot of work that's problem specific, but we kind of do it, we try to put it into a health system strengthening kind of approach. So a lot of what we do, and especially when we get dedicated funding by chronic disease or OPHPR, or, we'll try to meet your needs in that, but we'll kind of tie it in to not just sort of cutting to the immediate problem, but we try to do it in a way that gets at the deeper issues. So I'm going to just scroll through some of these without really stopping on them, but I may pause once or twice if I see something that's particularly remarkable. That's a community health center project in Kozrai that's new. Okay, and then I guess the other point I should make here is that, we kind of take a health system strengthening approach, and part of that is to work with other partners in the wider Pacific, and also to work with the professional associations that Amy mentioned. So, a lot of times if you go beyond just the funded people in, chronic disease or preparedness or whatever, there's other professional associations that kind of have a stake and that can kind of help along with making things work better. And we're kind of tied into that stuff. The other thing is a lot of times the approaches the CDC has are very similar in footprint to what WHO is trying to do or other partners, the Pacific community or other partners. And being tuned in to where are those areas of overlap can really save a lot of incoherence from happening at the jurisdiction level. Okay, and I want to say a little bit of a word now to sort of highlight and get a little bit deeper into DDM and SHIP with health information systems development. And I guess this is an example of one of those areas. I think a lot of you guys have projects going out in the islands, and you should be really proud of the work that CDC has done in the islands, but also I'm pretty sure that a lot of you are frustrated because you keep bumping in to some really, really difficult issues, intractable issues in at least three different spheres. And one of those is the handling and use of data and understanding of data and the reporting. It can be a really big mess. And I bet that most of you who are running programs are having problems with this. The second one is grants management and, the whole thing about using funds effectively and completely. That's a major headache for almost everybody across the board who invests in health programs in the US API. And then the third one is staffing and just public health literacy. of the staff and really being able to sort of get it when it comes to what you would like to see happen for population health. So I'm going to talk about the health information systems side of that right now, and some of the work that we've been doing for the past few years in this area. And the slide here is of Palau Community College, and the graduates there are a bunch of public health nursing BSN graduates who were in a FNU, Fiji National University, Palau Community College, PIHOA sort of joint program. So in basic public health literacy, I had a lot more domains to scroll through. Okay, so in basic public health literacy, we, for a number of years now, we've been building in-country college-level accredited public health training programs at a very basic level. Most of them are at the associate degree level. There's been some bachelor-level work in Palau and Guam. But most of our jurisdictions have public health training programs at their community colleges. So that's kind of the base of the pyramid when it comes to building basic public health literacy and also data skills. And then most of what I'm going to talk about is the second two levels of the pyramid, which is DDM, data for decision making, and SHIP, which is a FETP-like, EIS-like training program. So first, I want to give a little bit of a flavor. I don't know if this is going to work, but we'll see. I got a little video clip. And Abel, do we have sound on this? Can you hum and sing along? Okay. So this is just one of our partners from the University of Melbourne in Australia. Oh, there we go. All right. So this is one of the DDM modules that was given in Guam. Okay, so DDM has 5 courses. They're a week to a week and a half long. And, we give one, and then we wait for a month or so, and then we give another, and then we try to move cohorts through all 5 of these courses. And the idea is to kind of really, they're defined learning objectives and skills objectives, and to get cohorts of health workers from the USAPI to really understand data. So let's see. That's what the curriculum looks like. The yellow ones are the DDM courses. And then the second tier up, the OR, that's operational research courses. And that's about doing a research proposal, getting your data, analyzing it, and then publishing the results in a peer-reviewed journal. And then the top level of activities is finishing the rest of the fellowship. So we've run a lot of people through yellow so far, and we've pilot tested the OR level. And we're looking for, putting together, moving on to the rest of the blue and implementing it over the next year and a half. There's a timeline. I don't think I'll spend a lot of time on this, other than to say that the original DDM curriculum was introduced actually from a CDC curriculum also called Data for Decision Making Originally, it was just about outbreaks. In 2013 to 15, we revised the curriculum with our partners in Public Health Surveillance Network and made them more generic, so they're also about management, stats, and NCD surveillance, et cetera, routine reporting. And over the last year and a half, we've been delivering them in country. So we started the pilot tests as a regional thing, 1 or 2 participants from each jurisdiction. And after we revised the curriculum and it was approved by Fiji National University, we've moved it in country, and starting with the Federated States. And we've completed 6 jurisdictions, if we count American Samoa, that's finishing this week. And we have 2 in progress and 2 jurisdictions not yet. And it's not just training, but the longitudinal projects are really about getting into the engine room of the health information processes within the candidates' areas of responsibility and really codifying those, doing SOPs and designing dashboards, defining who the target audiences are for information products, and then running those through until they're functioning pretty well. So we aim by DDM to produce epi-technicians, so they're not fully qualified epidemiologists. They have about a semester plus of full-time data and epi stuff, but not really enough to be fully autonomous in that area. So far, here are the graduates. Just this week, there were 2 more that popped up because they finished their final projects. We've got 39 candidates who've gone all the way through the whole curriculum already, and a bunch more, probably 3 times as many, who've had some of the classes but haven't passed everything. Okay, so don't read all of this. I think if I boil this down, we're pushing out DDM and trying to saturate. We're trying to develop a critical mass of people who have basic data literacy in the health departments, really for everybody's benefit. And the proposition is that if there's a critical mass in each agency, things will work better because the reporting will be better, the feedback loops for decision-making will be better, and things will work better. But 1 semester plus of data and epi for 8 or 10 people in a health agency is not really enough to get things working very well. We'd really like to go on and do what it takes. And for any old-timers here, this is something that's been such a recalcitrant problem. For years and years, people have been moaning about, the sorry state of data and reporting in the islands and trying heroic efforts of workshops in this program, workshops in that program. And for this kind of stuff, you kind of have to go down to the roots and you sort of have to take whatever it's going to take sort of approach to fixing it. And for this thing, I think we're really starting to show some benefit. And I've heard a couple people even this week saying, oh, well, we have people who were part of this, and yeah, hey, they're getting it. It's easier to work with them. They understand their data better. And so I think we've made a good start of it, but we'd really like to go on to the ship. And that's kind of a hump because that's more intensive than just sending somebody around to do a course every month or 2 and then corresponding. It really needs on-the-ground faculty that are going to work intensively with people on a day-by-day basis with their counterparts and really bring them up to the fully qualified level. We're going to use the high flyers from the DDM stage to bring them along and try to bring them all the way up to the fully applied epi. I don't know how. I know how it's going to happen in terms of program design and how the thing rolls out, how it'll work. But I don't know how it's going to work in terms of how do we get the support necessary to do this, because it's actually going to be more resource intensive than the DDM. One of the activities that the full candidates are going to do is they're going to teach another round of DDM in their home jurisdictions. So we're hoping to even saturate the market for basic data literacy even more the second time around. So I just want to put that out there. Here are some of the products of DDM, annual profiles for various diseases, quality improvement, reporting, dashboards and SOPs, weekly surveillance reports that are designed to be very actionable. The yellow highlights are that week's alert threshold meeting counts. For weekly communicable disease reports, who's putting them out every week? When we started this in 2013, Guam was the only one that was getting out a weekly report. Now we have 7 of our 10 sites that are doing that. For for outbreaks, we have this sort of standard SITREP template that you guys working in Zika and preparedness have probably seen these for various outbreaks. And then there's been a whole lot of stuff, which I won't go into great detail, with NCD monitoring and surveillance and policy response. And there's a regional NCD surveillance framework, which is the first one anywhere that was done on a regional basis. This came out in 2012. And then the system to support jurisdiction level NCD surveillance plans that make sense and that are driven by the decision makers in country rather than external partners. And let's see, adult surveillance, hybrid surveys on a timely basis, and we're going from a place where we were kind of blind on a lot of that, and now most jurisdictions have fairly up-to-date data about adult risk factors and disease prevalence. Okay, so, and then some work on some of the surveys that need to feed into the monitoring and surveillance plans, both on the youth level and the adult level. And then dashboards to kind of report back and use for advocacy for NCDs. There's a lot of stuff here for preparedness and NCDs because those two areas have financed most of our DDM work. And so, again, what we try to do is do health system strengthening, but also address the needs of the programs that are interested and involved with this. Okay, so there's a regional NCD scorecard, and I don't think I'll go into this. Here's just a sample of where good surveillance and policy response really can move the dial. That's true of a lot of public health areas. Here's an example for smoking prevalence among high school students in CNMI. Back in 2003, 50% of high school students were smokers in CNMI. In 2015, it's down to 18%. Major, major impact. Lots of people getting protected from getting hurt. Okay, and then just to wrap it up, how do we work together with CDC? Well, I think PIHOA, we have to offer a connection with the leadership, the health leadership, and also some of the, even beyond the health sector, the legislative and chief executive leadership in the islands. We have context expertise that can be helpful to you guys, I think. We have institutional memory, what's been tried before, what hasn't worked, what has worked, and that might be helpful to you guys. We sort of are generalists, so we can take your program-specific concerns and we can work them through a health system strengthening kind of a lens. We have deep connections with WHO and et cetera, the other institutions, technical assistance agencies working in the Pacific, so we can help you to avoid duplication. And we're pretty good with resources and getting things done pretty quickly because we're small and we don't have to have a really bureaucratic structure. So I think that's all I have to say, and I'll bow out here and turn it over to whoever's taking over. Is that Angie? Okay, Angie.